How about now? Okay, great. I'm going to start talking a few things while I know there's a few people that say they're going to be a little late for a few minutes. So, uh, good evening. This is our September 21st webinar group meeting. I'm sorry that we've missed the last two. We've had some unexpected things come up. And the two topics that have come up, and actually there's been some specific questions people have asked us. One of them was to discuss hypoglycemia, and the other topic was to talk about thyroid dysfunction, hypothyroidism, and sort of a bigger global approach as to its relationship with obesity. I have a split screen, so I'm not looking away from the monitor, but my data I just have to grab and drop it into the field. So what I like to do is I'm going to go ahead and get started. And what I'm going to do is that I'll start with the thyroid discussion that I think we had some time ago. So I'm going to use the same slides, but I'm not going to try to bore everyone with the same content again. So I'm going to go through some of the slides. I'll skip through some of the slides, but there's some other information that I've written down. I'm going to talk about that. So the effect of thyroid dysfunction and obesity is interrelated. And so our understanding has been that patients with hypothyroidism do develop obesity. There's a significant amount of evidence that obesity indirectly, because of its inflammatory state, may actually contribute to hypothyroidism, and that sort of ends up in a vicious cycle. Now that I'm hypothyroid, so I gain some weight. My weight gain may be more in the fat cell type versus muscles. Fat cells provide an oxidative state, cause inflammatory cells to be released, and inflammation causes neuron damage, and we'll talk about that a little later. So that vicious cycle essentially feeds into it. Real briefly, again, I'm going to go through some of these slides very quickly. Thyroid gland is the largest endocrine gland. It's bilobed. There's two left and right, and there's an isthmus in the middle. And the software is supposed to have been updated. Does anyone see the mouse on the slides or not? The thyroid itself has two lobes, the left and right, and there's a connective bridge. It's called the isthmus. Thyroid gland is different than parathyroid glands. We worry about parathyroid gland as it relates to vitamin D and calcium metabolism. That's different than the thyroid gland. We're just going to focus our discussion today about thyroid gland. The thyroid itself controls a whole slew of metabolic pathway, protein synthesis, heart rate, sensitivity to other hormones, or temperature regulation, and so forth. The hormones that are produced are the T3 and T4. They're thyroidine and thyroxine, and calcitonin, which is instrumental in calcium hemostasis. And again, thyroid and parathyroid are in the same place, but they sort of parathyroid are deeper to the thyroid gland, but they're all they of different function. Just real briefly, the gland itself, the thyroid gland is sort of the mid-bridge of this complex pathway that actually starts in our hypothalamus at the brainstem, sort of not brainstem, but behind the bridge of the nose, at the base of the skull. And so the thyroid releasing hormone, the TRH, thyrotropin releasing hormone, the TRH, is released from the hypothalamus, which stimulates the thyroid stimulating hormone through the hypothalamus, and that goes into the thyroid gland. and the thyroid stimulating hormone releases cause production T3 and T4, which they go to the end organ and they have the end results, which is the pathways, temperature regulation, heart rate, and so forth. With a high level of TSH, you have a negative feedback, which goes back to the anterior pituitary and the hypothalamus, in which cases it says, well, we have enough TSH, so turn this off. So this prevents the system from crashing by overproduction of a T3, T4. The system works ironically when, for example, there is no inflammation, there's no receptor blockers of some sort, either one of those two levels, and obviously if there's no malignancy. And any one of those criteria, any one of those categories may break down one of those regulatory steps from TRH to TSH or TSH to T3 and T4, in which case you may have an overstimulation without any feedback turning off the precursor, and so the body produces either too much of one thing or not enough of things without responding to the proper stimuli. So again, it's just a larger version of this. So the TRH released from hypothalamus into the anterior pituitary, TSH from anterior pituitary to the thyroid gland. Thyroid gland produces the T3 and T4, which is also, we'll talk about a T3 or T4 convert, and then that regulates the mechanisms, in which case goes back to hypothalamus and turns down and down-regulates the TRH, which in return down-regulates the TSH and so forth. So this cycle repeats itself to make sure everything is properly regulated. We talked about the negative hormones. Just a blow-off of the molecular pathway that takes place. So on the right, on the screen's right-hand side, we have the bloodstream where the iodine and the sodium are co-transported into the thyroid follicular cell. These are the cells within. So if you take a thyroid gland and under microscope, you cut it, you'll see these long vertical tunnels, and all of those tunnels have these follicular cells lined up, and they function by obtaining the ingredients from the blood side, processing and dumping it to sort of the center of the cells themselves. So if you follow this, essentially sodium and iodine are absorbed, they're packaged, then they're pushed into the center of the thyroid follicle, the cells itself, where the thyroid molecules are produced, the T3 and T4. And when they're sort of pushed back, now we've gone through the cycle into from the blood side to the left side of the screen, and now we're coming back through the two open and closed circles at the bottom of the screen through the monocarboxyl transport receptor, the green tube, and then that's when the T3 and T4 are secreted into the bloodstream. The T3 and T4 function are produced in the thyroid function require daily iodine, so our body needs to absorb the iodine on a daily basis. We really don't have a lot of reserve of iodine in our system. Deficiency of the iodine decreases production of the T3 and T4. 20% of the thyroid hormone is T3 and 80% is T4. T3 has a greater action on target tissue than T4, so you get a lot more bang for your buck with the T3 and T4, even though we have a lot more T4. T4 has a longer half-life, and the T4 can be cleaved to produce T3. So our thyroid produces T3 and T4. T4s are, if you would, shorter acting, much more potent. T4 hang around longer, but they're not as potent. But when the body needs it, the T4 can be broken down to a T3 by kidney and the liver, and to do its job essentially. Some of the basic stuff with thyroid function regulates the metabolic heart rate, brain processing, menstrual cycles, cholesterol, and circulating plasma is cleansed off. Converts the keratin to vitamin A, and so patients with hyperthyroidism, theoretically with normal vitamin A level or keratin level, will also develop significant night blindness issues. Increase the rate of glucose absorption through the small intestine, and control heart rate, cardiac output, increase gut motility, and ventilatory support response to hypoxia. So, without going into the details of it, if we step back and say, well, so what does thyroid hormone do? it's easier to appreciate what does a patient who has hypothyroidism feel. A patient with hypothyroidism may have is fatigued all the time. They may feel very cold or very hot. They may gain weight significantly. They're sluggish. They may have low blood pressure. They may have poor cognition. They're not as sharp with their answers, with cognitive processing, and so forth and so on. Female cycles may be off. Infertility may be an issue. So essentially, anything that drives the engine for all of the metabolic pathway gets screwed up if you don't have enough thyroid in the system. The thyroid panel, the basic thyroid panel, just sort of briefly on the table, it says in a hypothyroid state. So when my thyroid is depressed, the TSH, the thyroid stimulating hormone, that's the one from the anterior pituitary that goes to the thyroid gland, is increased, which wants the thyroid function to produce more T3 and T4, and in this case, T3, T4, and the free T4 are low. In a hyperthyroid, in a patient that you have overactive thyroid, and we'll talk about what you may have, that's Hashimoto's thyroiditis, which is an inflammatory state where the thyroid is overactive, it's enlarged. You may have a lower TSH, but high T3, T4, and free T4 levels, and those essentially represent what we talked about with the negative loop back of the TSH regulating the thyroid function in response to what's coming back from the bloodstream. So because we have high T3, T4, and free T4 in the hyper state, those circulating to the system go through the back loop to hypothalamus, through the anterior pituitary, and says we don't need, so TSH gets down-regulated, so not enough is produced. I'm going to skip through this. The T3 uptake measures the level of the, just briefly, someone had asked me about what those lab indexes mean. The T3 uptake measures the level of the protein that carries thyroid hormone in the blood. So thyroid itself needs to be sort of bound to a protein to carry it around. The thyroxine binding globulin, it's sort of the carrier protein for the T3 and T4, and the reference numbers are usually about 25 to 40% of saturation of those protein that carry the T3 and T4 around. Oops, wrong one. Hypothyroidism, it's decreased T4 and T3 and increased TSH. We already talked about that. Skip this. Increased thyroid hormones. Hyperthyroidism is the opposite of it. Increased T4 and T3 and decreased TSH. But actually, I should go back and mention one thing here too. So with the hypothyroidism, this is when a patient is hypothyroid, which results in weight gain and things like that. An example of that would be Hashimoto's thyroiditis, which is an autoimmune condition. We'll talk about the inflammation here in the next few slides about that. When we talk about increased thyroid hormone, this is hyperthyroidism, sort of a Graves' disease. And for those of you that may want a visual, sort of the descriptions of a patient that looks, their eyes are wide open and hyperactive, agitated type of a thing. This Graves' disease is the autoimmune version of that, and that's a sort of thyroid stimulating immunoglobulins such as the TSH are where the antibodies are formed, and that continuously is stimulating thyroid glands for overproduction of this. So the point of this is not to get into nitty-gritty of the thyroid, but appreciate that though the problem with the thyroid may be intrinsic to itself because of iodine deficiency, and or it may be intrinsic because of inflammatory causes that may be contributed by our diet or obesity, which sort of end up being a vicious cycle, and that can be hyper or hypoactive. Thyroid hormone replacement, T4 hormone replacement of the choice. It has a longer half-life. It's better absorbed through the GI tract. And as we talked earlier, the T4 can be broken down and have a T3, which is the more potent, shorter half-life. T4 also helps regulate the negative feedback loop, lowering the TSH level once the proper thyroid function is achieved. Standard treatment for underactive thyroid is supplementing with levothyroxine or the Synthroid. Requires about 1 or 2 weeks to see effectiveness. This does not get corrected overnight. Requires adjustment based on age, based on basal metabolic rate and activity level. And one of the side effects and sort of one of the early warning sign of overtreatment with a patient would be cardiovascular. Sort of patients develop high heart rate and so forth, and those can become an issue. Then we talk about the bovine versus synthetic hormone. Bovine supplements are natural, made from dried and powdered thyroid gland of cattle, available over the counter or prescription. It has minimal side effects, and depending on whether you get the over the counter and or prescription, I've really not found much of a precise information. There are some people that are saying that overdosing may be easier on this because of the variability in the production method and the variation between a single dose to second dose, a batch versus a second batch. Synthetic hormones are available by prescription, not natural. There's a possibility for allergic component and moderate adverse effect. And just like I said earlier, overdosing is always a concern, but at least it's predictable when it compared to bovine. The issue with the bovine dosing issue has been pretty much regulated much better, but there's still something that's mentioned. There are patients that actually don't do well with the synthetic thyroid and they just don't respond, and in which case the recommendations are to go to bovine supplement. What I was going to talk about is that there was a study many years ago, a few years ago from Yale that talked about the issues with regards to significance of inflammation and thyroid dysfunction. As bariatric surgeons, one of the things that we see is subclinical hypothyroidism. So a patient that says, I have my thyroid panel, I'm followed by a physician, endocrinologist, and my TSH, they say it's 1 point something. My T3, T4, free T4 is all normal, but I don't feel good. I'm sluggish. I am depressed. I've got very fine hair. I've gained weight. I'm missing my periods here and there. So if you were to sort of ignore the laboratory studies and listen to the patient, as I said earlier, you have what's known as a subclinical hypothyroidism. You've got a patient that essentially has all of the signs and symptoms of hypothyroidism: the cardiovascular, endocrine, overall constitutional symptoms, hair loss, depression, and so forth and so on. So those patients should be treated with thyroid medication. So, sort of treat the patient, not the labs. And that's where we find ourselves in some predicament where the physician treating the thyroid dysfunction will rely on the laboratory studies a lot heavier than we will, and then so we're sort of always at this position. Well, the patient's clinically is hypothyroid in lieu of their labs being normal, so we have to try that. So the study from Yale looked at this from a different aspect of it, and specifically when we talk about the obesity, the obese state, inflammation caused by obesity itself, the issue would be things like, in general, obese metabolic presence causes inflammatory cells, and joint pain and things like that, and inflammatory markers, cytokines and things like that are always elevated. Some of us may have had blood drawn, the SED rate, for example, which is also mildly elevated. So there were three specific issues that in the study by Yale, they found what the T helper cells do was that in an inflamed state, so a patient that has inflammation, whether that's caused by obesity or other, and this was done experimentally too, is that inflammation itself will do a couple of things. One of them is that it suppresses the TSH, T4, T3, and the thyroid releasing hormone. So a patient that was injected with an inflammatory cells, the cytokines, for a duration of, I think, 5 to 7 days, they thyroid, all of the hormones relating to thyroid dropped down. So the TSH, TRH, T3, and T4 went down. Inflammation also can decrease the number and sensitivity of the thyroid hormone receptors. So what that does is that, though, I may not only have less T3 and T4 because my TSH and TRH is depressed because of inflammation, the T3 and T4 that's depressed is released can't do the job because there's less number of receptors and the sensitivity to the thyroid itself is depressed. So this whole cycle of hypothyroidism causes obesity, or obesity exacerbates hypothyroidism, seems to be more of a circle that they feed into each other. Which, as I said a little earlier, what we see is a lot frequently a clinical hypothyroid patient who has hypothyroid problems, not on laboratory, but on all clinical manifestation, in which case the way to treat that would be up the thyroid medication. One of the stuff that we've heard patients are told is that the downside of treating the thyroid, I don't want to say aggressively, but proactively, let's say, endocrinologists and primary cares would certainly, but this is a valid point, they'll raise this issue, is that it can actually cause speed up osteoporosis. So if I am a patient and I have issues with osteoporosis, but my thyroid is also worse, and I get on medication, I will develop osteoporosis at a higher pace. My counterpoint to that has been that an overweight patient who may be clinically hypothyroid as an inactive is probably as much risk overall as it is for a patient who has hypothyroidism that's addressed at an increased risk of osteoporosis. So just keep in mind, the patient with thyroid should be very vigilant with all of their other supplements, vitamin D, calcium, to make sure they don't sort of walk down that road of developing osteoporosis. The other issue, the other question that I was asked with regards to thyroid and vitamin D was that vitamin D itself, as the slides talked about, thyroid function is imperative for proper gut absorption. So from a GI point of view, we do need a proper thyroid levels for the mucosal cells to be able to absorb things. So whether that directly or indirectly plays any role in vitamin D, I don't know. But overall, the concern from a bone health point of view would be thyroid medication can cause osteoporosis, and it would be important to stay on a high vitamin D level. I'm going to shift gear and talk about the other topic that was raised. And if anyone has any question, please feel free to ask while I'm looking for the paper here. So one of the other topic that we were asked to address was the issue of hypoglycemia, and the relationship between hypoglycemia and weight loss surgery, specifically with the duodenal switch operation. So interestingly, we have we've submitted a paper for publication that specifically deals with hypoglycemia and Icd blastocyst, and that's sort of the technical term of a highly specific condition with the end result being low blood sugar. I want to sort of take a step back and talk about the gastric bypass patients that have issues with hypoglycemia, because I think it's important to appreciate the connection between that and the duodenal switch operation and its manifestation. Hypoglycemia essentially refers to when a patient's blood sugar drops down and patient may become symptomatic. That can happen to anyone that has had weight loss surgery or not. If I don't eat for a long period of time and I'm out there and burning a lot of activity, my blood sugar may get down so far out as, we have different manifestations, sweating, a little jittery, irritated, and usually it starts with patients having something sweet to eat. The opposite of that, another way this can happen would be if actually a patient eats too much sugar, gets a spike of a rapid rise, and then on their way down, because the blood sugar is dropping down because of over responsiveness of the pancreas to normalizing blood sugar, the blood sugar drops down. That second mechanism is how you sort of loosely can define dumping syndrome as. In a gastric bypass patient who has dumping syndrome, what they're experiencing would be the unregulated passage of, and we can talk about in great detail about dumping syndrome, but just as it pertains to hypoglycemia, you have an unopposed, unregulated passage of carbs from the pouch of the stomach into the small bowel. As that food travels down the length of the small bowel through the Roux-en-Y, the sensors that are sensing the sugar content, both in the very top part of the stomach and the small bowel, will send a signal to the pancreas that warns them that there's blood sugar coming, that there's sugar content coming down, and that's supposed to release the insulin. That rapid rise of the insulin will control the blood sugar, overcorrect it, and then the patient develops a shakiness, dizziness, palpitations, sometimes passing out. The reason why that, I want to say theoretically should not and does not happen with the duodenal switch operation is because there is no unregulated flow of anything from the stomach into the small bowel in the duodenal switch operation. All of that regulation still goes through the pyloric valve, which is supposed to control the passage of the food from the stomach to the duodenum. So the food cannot pass, and as it goes through the pyloric valve into the duodenum, the control is flowed, so there's much less bolus feeding of the small bowel with sugar content, so you have less spike of the blood sugar in which the pancreas responds by overstimulation. There are some patients that will describe similar symptoms of hypoglycemia after duodenal switch operation. In our experience, when we looked at our data, and we looked at this publication that's going to get published soon, we specifically looked at all of our revision patients. And we looked at a subset of patients that had revision mostly because their predominant problem was hypoglycemia, Icd or symptoms of hypoglycemia, not necessarily the weight regain after gastric bypass. And all of them had resolution of their symptom. Patients that are experiencing symptoms similar to hypoglycemia with the duodenal switch operation may have to really go back and look at two elements: is how far are they from their weight loss surgery? And patients that have lost a lot of weight have depleted all of the peripheral sources of stored calcium, of the sugar, and stored sugar, and their blood sugar is now very closely related to how much is consumed at any given point in time, how my blood sugar drops down, how my body responds. What we need to do is to have the patient step back and look at their carbohydrate intake in a form of distributed throughout the day, ideally in the form of a complex carbohydrate versus things that are simply broken down and increase and decrease the blood sugar too quickly. That's one variable. The other variable is if there really has been any issue with the pyloric valve or surgically, that may account for easier passage of food content from the stomach to the small bowel. One specific case that our review of our own data showed, and we had to look away from it, was that the patient that had a transected gastric bypass, we assumed the vagus nerve was gone, was having a lot of post-revision and about a year or so post-revision nausea and bloating, sort of gastroparesis, and the GI was consulted, and the GI did a balloon dilatation of the pyloric valve, and whether that contributed to the big picture, it's hypothetical. So that patient was excluded because it just didn't the information didn't pan out on our paper. So looking at the hypoglycemia, by definition, that would be if I have something sweet, there should be a predictable response of my blood sugar going up, and then insulin kicks in, hormonal proper pathway takes place, and my blood sugar stabilizes and comes down. In a patient that may have a hyper-responsive state, the blood sugar may go up, and then the bounce back would be much more abrupt and drop down. And these patients don't have the glucose tolerance test that's normal. Causes of this in a patient who's not weight loss surgical patient or has had not any weight loss or any surgery for that matter would be things like sorry, my phone is beeping here, turn it off. Would be things like patients that have insulinomas. Insulinomas are these solitary tumors of the pancreas that are round, located, isolated, and sometimes in tail of the pancreas, for example, and they release specifically insulin. And a patient presents with a symptom of blood sugar dropping for no good reason. You check an ultrasound, get a high insulin level, and that surgically gets removed. Counteract the similar physiologic response to that is nisidioblastosis that we looked at specifically. And nisidioblastosis is overall, unlike the insulinoma, when there's one single cell, one single sort of a small marble of insulin-producing tumor within the pancreas. In nisidioblastosis, you have all of the insulin-producing cells in the pancreas have gone overactive, overexcited, and much more proficient into producing the insulin. Causes of nisidioblastosis are not very common. Interestingly, there's a lot of talk about this within the weight loss surgical community because we are proposing with our study that the treatment for nisidioblastosis and hypoglycemic episode and symptomatic hypoglycemia after gastric bypass should be revision to the duodenal switch operation, whereas others have unsuccessfully advocated and promoted very rigorous dietary changes, which we know it has very limited outcome, and as an extreme is near total pancreatectomy, which they go in and remove about 80-90% of the pancreas. And if you do literature search, and again, our paper has all of the references, the interesting thing is that though is there is really no good consensus as to how much pancreas to take out, because there's a number of studies and a couple of papers came out of Mayo Clinic, I think it was Cleveland Clinic, that showed that if you do like an 80% pancreatectomy, you remove 80% of the pancreas in order to reduce 80% of those cells that produce a lot of insulin causing hypoglycemia, you may still leave enough behind that patient doesn't really do well. there's still so much production, over abundance of the insulin that the patient's still in trouble. In contrast, if you go to like 90-95% pancreatectomy, a subset of those patients, you've taken so much pancreas out that now they've become diabetic. So to us, that sort of is not a really rational approach. And with our study, we showed essentially the issue, the study to, the way to address this would be do the duodenal switch. And so I'm going to show two things here. Let me sort of I'm assuming you folks can see my screen here. Yes, no? All right. So this is just sort of the distinguish between insulinoma and nicetioblastosis. Insulinoma is, again, when you have that single solitary tumor that produces the insulin. Nicetioblastosis is overall hypertrophic pancreas. Imagine nicetioblastosis is essentially a muscle of the pancreas that has really worked up. It's got this big, juicy, nice, thick stuff of pancreas, if you will, and there's a cartoon for you. So the differences between these two is that in insulinoma, you have, in insulinoma, you may have, in fasting, insulin level is elevated. So because insulinomas continuously sort of secrete the insulin, whereas in nicetioblastosis is decreased. Postprandial, after you eat, the insulin level goes up again, sort of proportional to the amount original to the insulinoma, whereas in nicetioblastosis, with the 3 arrows up, is significantly higher. The fasting glucose may be low in insulinoma usually because in the background, as the first column shows, they have higher than normal insulin level, whereas in nicetioblastosis, the blood sugar would be high because they have less of insulin at the baseline being released. 1 hour postprandial, blood glucose may still be high with insulinoma. Their baseline is always high, whereas in blood sugar with nicetioblastosis drops down significantly. So the bottom line and the last column, the screen's right-hand corner, is essentially what drives the symptoms of symptomatic hypoglycemia. And in extreme cases, you get nicetioblastosis. And the treatment for this would not necessarily be to remove the pancreas. Specifically, the other thing that we sort of looked at, and this is one of the slides that I can't show because the other ones are sort of on a copyright and I can't share it right now till it gets released, is that the starting weight of the patients that had this is a sample table of the patients that had their gastric bypass. So I'm going from left to right. Those are the patient's height and truncated the rest of the table. Those are the first green column on the left shows the BMI and the starting weight before they had their gastric bypass. Then you get that white column, the lowest weight and the BMI represents the lowest weight and the BMI the patients had after getting gastric bypass. And then the white column in the middle and the next column next to it to the right is the weight at the time of the revision and the BMI. And you can see some patients had some weight gain, some did not. And the purpose of this study in this group was to specifically demonstrate that duodenal switch operation is better for patients with nicetioblastosis, just for the treatment of nicetioblastosis, independent of the weight. And in this subset of patients, this handful of patients that I've sampled here, you can see that their BMI before, the lowest BMI they had after their gastric bypass and the time of the revision is sort of relatively close to each other, not identical. And the last three columns show how we, I do the Hess method of the with the duodenal switch. I think it's every patient should have their entire length of the bowel measured, and then the common and alimentary should be made as a percentage of the total length. And this is the numbers that represent as to the patient's length were measured: 700, 700, 800, 750, and so forth. And then you can see the column of the alimentary and common channels. And these patients had all had resolution of their Blastocyst or severe hypoglycemic episodes. The interesting thing is that when we extend this data and look at all of the revisions that we've done, and the patients that had hypoglycemia and/or dumping syndrome marked as one of the conditions for which, in addition to the weight regain, the data was very parallel. The reason why we excluded those was because we didn't want there to be a built-in bias as to someone saying that, well, if you revise the Roux-en-Y, then that would have solved the problem. This data explains that if you just look at the disease of blastocyst hypoglycemia, the problem gets resolved with the duodenal switch operation. This sort of brings me full circle as to the question that I was asked as to, I have duodenal switch operation and I'm getting dizzy and I have to feed myself all the time, otherwise my blood sugar drops down. That may or may not necessarily be hypoglycemic episodes unless I really sit down and have a whole bunch of, chocolate chip cookies for breakfast, lunch, and dinner. And then if I don't eat any protein to sort of build my baseline of the background blood glycogen stores, I would end up dropping my blood sugar and become symptomatic. The patients that may experiencing this may have to worry about more things like, do I have enough glycogen, long-term stores? Am I getting enough protein? Am I getting enough amino acids? And not to alarm anyone, but in extreme cases, actually, and in an ICU setting, in intensive care unit setting, low blood sugar in a patient that's getting enough nutrition may be a sign of liver-related problems. So again, I'm not saying anyone to be alarmed, but that those are the sort of algorithm that in our mind we need to make sure that you've checked on this. It's not a diet. It's not Insulinoma and Icd blastocyst. You really can have this. You can have insulinoma even after duodenal switch operation, but that's not there. And it's primarily diet driven in our experience that we've seen. That has to do with too much of a free, easy sugar that results in spike of a blood sugar, spike of an insulin, and then everything crashes down. That's sort of all I had to say about that. And sort of a completely off topic and an unrelated thing with regards to this is also the amount of protein intake. We did have a slide, a webinar that we talked about, or I think may have been a blog that we wrote, had to do with protein absorption and so forth. I want to remind all of us that if you think of this pathway of carbohydrate, fat, and protein, they all go into the Krebs cycle. They all feed into one sort of a refinery. And the end result is the currency that our body uses, ATP, adenosine triphosphate, that feeds into the system. We can actually have too much of a protein, which is not good. A patient that may be experiencing plateau of a weight and they think that, well, I'm eating a pound of coconut oil and 200 grams of protein and I'm there running every day, maybe over consuming too much of a good thing. And all of those in a form of the fat, carbohydrate, and protein, even though I'm skipping all of the carbohydrate, I'm skipping all of the bread and the pastas and things like that. By taking too much of a short-chain amino acid that may get absorbed easily and too much of a protein, I'm overwhelming the Krebs cycle, which its job is to essentially take all of the stuff that we give it in, produce the currency ATP, and feed it into the system. And if I'm overdoing this, I may be creating way too much stuff, shifting the basic metabolic pathway where you can actually start storing fat by consuming protein. by consuming short chain amino acid. It's very important, or medium chain lipids. So it's very important for us not to overdo things with regards to the protein. The argument for trying to do large volume of protein will be exercising too much. But again, that needs to be balanced. Unless someone is running 50 miles a day, there'd be very little reason for someone to actually consume 150, 200 grams of protein without really having a justifiable way to account for how that's being burned off, essentially, for example. I don't know if this will be relevant to anyone or not, but also a question about a feeding tube. With regards to the feeding jejunostomy tubes versus feeding gastrostomy tubes, feeding gastrostomy tubes are placed in the stomach in front of the pyloric valve. Feeding jejunostomy tubes are placed behind the pyloric valve into the small bowel. You can actually have dumping syndrome if you give yourself a large volume of either sugar or fat or just too much of a volume into the feeding jejunostomy tube, because similarly to the gastric bypass physiology, where it's an unregulated food going down the small bowel, feeding tube feeds into the J tube, jejunostomy tube, feeds into the small bowel in an unregulated format. So if I milkshake and dump it down into the feeding tube, I just gave myself a big bolus of sugar, and I may have symptoms of the dumping syndrome. Whereas if I have a G tube, a gastrostomy tube in my stomach, and I feed the milkshake into the gastrostomy tube, the pyloric valve, in theory, should be able to regulate that flow, so I really shouldn't be having dumping syndrome. Any questions? So when it comes to the amount of protein taken additionally in general surgery, critical care, trauma literature, which is most of the research is located, we sort of have 1.5, 2.5, 3.5 grams per kilogram of ideal body weight. So a patient, for example, that has a normal basal metabolic rate, you want to have 1.5 gram per ideal body weight. So a patient that's 100 kilos should be having about 100 grams of protein a day. A patient that's 100 kilos and shows up in an ICU because of a car wreck or a burn injury, then we up that up to about 3 grams per kilogram. So a 100 kilogram male patient that was in a trauma and they're in an intensive care unit, they will require 300 grams of protein a day. And there is a maximum limit of how much you can. The 3 grams is sort of pretty much maxed out as to how much your body can process and not being able to absorb any further. So those the maximum amount and the minimum amount are sort of the boundaries. And again, the patients sort of need to play with that. Too much of protein is not going to do anything other than result in weight gain or inadequate weight loss, essentially. Any other questions? When it comes to the increase, there's a question here, increased protein intake, anything that essentially stresses the body. As I said, trauma, injury in female patients, maybe things like trauma, pregnancy, which is at the cellular level very traumatic, and patients that are undergoing plastic reconstructive surgery. That's, for example, when we see a patient there are patients and we're doing any hernia repair, penniculectomy, or anything like that, we will make sure that their protein levels are normal. And if it's not, we will not operate on them. And that, it's not infrequent. Every so often we'll see patients that come back to us a few months after they've had penniculectomy, abdominoplasty, or something else somewhere else done, and now they're complaining of significant swelling of the feet, and their protein levels are 2.5, 2.0, albumin level is 2.5, 2.6, protein level is 5 point something. And what may have happened is that before the surgery, their protein level was high enough to maintain themselves, but they did not have enough reserve to be able to tolerate the stress and the injury of a major surgery. And they've depleted all of their sources, and now they're hypoproteinemic, hypoalbuminemic, low protein albumin level, and that causes the swelling and the third spacing of the fluid and things like that. Unlike a lot of electrolytes, actually, you can't also sort of bump your protein up by eating too much steak overnight and bump this up. This sort of needs to be, if I really need to be planning on something and my protein is low, I just need to add a little on a continuous basis, repetitively throughout the day for weeks and weeks at a time, versus just a whole bunch of overdoing it in one setting and over a short period of time and expect for that to correct the problem. Any questions? Great. Okay. If there's no other questions, I'll go ahead and conclude this. I'll leave this open for everyone for a few minutes. And we will have this webinar on our website the next few days. Our research paper will be, we've chosen it, we've decided to publish in an open source journal where it will be accessible to everyone, and we should have confirmation dates and this and that in the next few weeks, and when it's available, we'll put that up there, and we'll also put up our webinar for the metabolic pathway also on our website. And thank you very much, everyone.